You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everybody, and welcome to the show. My name is Sebastian Lopez Steven, and I am a second-year medical student at UBC. The episodes that I'll be hosting with Just Medicine really focus on migrant farm worker health. This is a topic that I've been really interested in since right before medical school and now continuing into medical school, as I am the head of the University of British Columbia's Bike Kitchens program called BC Libre. In BC Libre, we rebuild donated bicycles so that they can be donated to migrant farm workers who can use these bicycles to access healthcare appointments or just to get off the farms when they would otherwise not be able to. I think what's important for a lot of these episodes is that some individuals here in British Columbia may not know about the impact of migrant farm workers on the agriculture of British Columbia and the way that these individuals receive healthcare when they come into Canada, as they are temporary visitors or immigrants from other countries. So I think what's important before diving into some of the conversations that we had with healthcare providers who are focused on providing support for migrant farm workers is to really have a good basis of understanding for the health of migrant farm workers here in British Columbia and Canada as a whole, and how advocacy has helped and what kind of avenues are needed next. It's likely that whoever's listening to this is going to be somebody that is coming from a healthcare profession or at least is working towards getting to a healthcare profession, but I'm asking for anybody who's listening to this to really try to stay engaged for as much as possible when it comes to immigration policy, because immigration policy is really the foundation of any of the health concerns that we have for migrant farm workers. We'll start our conversation really at a large federal level when we talk about the Temporary Foreign Worker Program. This is a federal program in which the federal government allows Canadian employers to hire foreign workers to fill temporary jobs when qualified Canadians are not available or they're not applying to those jobs. In British Columbia, anybody who's hired under the Temporary Foreign Worker Program is protected from unfair practices under the Temporary Foreign Worker Protection Act. This whole act and the entire program is regulated by Immigration and Refugee Protection Act and is administered by the federal government and the CBSA. One of the streams of the Temporary Foreign Worker Program is the Seasonal Agricultural Worker Program. In this scenario, citizens of Mexico or other participating Caribbean countries, including Barbados, Dominica, Grenada, Jamaica, and St. Lucia, can all be hired for a maximum period of 8 months to work temporarily in Canada. Individuals that can be hired are those that are experienced in farming, are 18 years or older, a citizen of one of the participating countries, and those individuals that satisfy the Canadian immigration laws and the laws of the worker's home country. What's important in this whole situation is that in exchange for being allowed to hire from outside of Canada, employers need to provide their temporary employees with resources. So this includes that the employer must pay for the airfare to and from the home country of those individuals that they hire for, and they also need to provide transportation between on-site and off-site accommodation and the workplace. Under the Seasonal Agricultural Worker Program, employees need to provide housing that is adequate, suitable, and affordable as defined by the Canada Mortgage Corporation, and it can't be any higher than an acceptable occupancy rate that you would imagine would happen in the general public. As well, employers need to ensure that temporary foreign workers under the Seasonal Agricultural Worker Program register in their provinces or territories' health insurance program, or to provide them private insurance in the meantime. Often, this kicks in within 3 months, but sometimes private insurance is also a way to go for extended health. Something that's important here is that employers need to provide the same wage and the same benefits as those provided to Canadian and permanent resident workers in the same occupation when they hire temporary foreign workers under the Seasonal Agricultural Worker Program. And most importantly for these individuals, work permits for the Seasonal Agricultural Worker Program are tied to the employer. And so this means that individuals who are concerned about being deported would often fight to keep their job, because any loss of the job here in Canada means that they have complete leeway in order to deport them. What's another important fact about the Seasonal Agricultural Worker Program is that these migrant farm workers are eligible to be terminated for any reason without any kind of ability to advocate for their job back. And so what you end up with are individuals who are really wanting to keep their jobs, because keeping their jobs means that they can send money back to their family at home, and they're making significantly more here than they would in their home countries. However, any information that the employer receives that could motivate their termination of their employee causes a problem, because then these individuals are hiding information about themselves that they fear might get them fired. And one of the most important things that we see in this population is that migrant farm workers, especially in British Columbia, will often not report to their employer that they have a healthcare concern, regardless of how significant it is or whether it impacts their work, because that could give a motivation to employers to terminate their employment and receive another foreign worker who theoretically would be in a healthier state. I think now we can kind of mercifully move back into more of a social determinants of health discussion and more of a medicine discussion when we look at the findings that were in the What We Know report from 2022, which explored feedback from stakeholder consultations on the current employer-provided accommodations in the agricultural sector within the Seasonal Agricultural Worker Program. This report found that the temporary status of temporary foreign workers and seasonal agricultural workers makes them susceptible to potential exploitation and abuse. So for context, you've got about 60,000 foreign agricultural workers that travel to Canada each year up until 2022 when we have the last stats. And 60% of all foreign workers were entering Canada under the Temporary Foreign Worker Program. The report found that while the majority of agricultural employers seriously regard the health and safety of their workers, there remains challenges to be addressed within this field, and you have individuals that need to be reprimanded for bad treatment of their employees. Some themes that were identified in this report were privacy and overcrowding. There was a push for bunk beds by employers that would exceed the occupancy rate that was allowed for the accommodations that were provided, and that would exacerbate issues of privacy and overcrowding, which puts individuals at mental health risk and also puts them at risk of transmissible disease. The health and safety of workers was also touched on in this report, and it was noted that air and water quality needs to be improved in certain spaces, and there's a need for improvement on cleaning, sanitation, and maintenance across the boards in a lot of these agricultural sectors. When we dive more deeply into the actual health outcomes of temporary foreign workers in agricultural sectors, Salami and colleagues did a scoping review in 2015, which found that migrant farm workers here in Canada are experiencing discrimination and exploitation as often full, undesirable, low-skilled positions with inflexibility, insecurity, precarious employment, and long working hours with low pay. Occupational health hazards were a big issue that were found in this scoping review as negatively affecting workers, and this includes falls, vehicle accidents, or any other kinds of accidents that happen on the farms. This report similarly found overcrowding living facilities, inadequate hygiene and sanitation across the board in the job sites. Maintaining the mental health of migrant farm workers was also a challenge, where these individuals were feeling lonely and felt the injustices and powerlessness within their job site. In fact, in 2011 alone, 25 individuals were repatriated simply due to mental health concerns. The report concluded that immigration policy that places a worker's health into the hands of a single employer has the potential to lead to exploitation and create barriers in access to health services, as the employer has a role to play in whether that worker remains in Canada. This is something we discussed at the top of the podcast, and I think it's important to reiterate here that you have individuals that are being brought into Canada, are being maltreated when they're here, working too hard, and are relatively unable to access healthcare because it comes at the cost of possibly losing their job, which is supporting family back home or supporting themselves in the future. What's interesting about this program, though, is that you can continue to rehire these individuals each year. So even though they're seasonal agricultural workers, they can be brought back each year to the same farm as long as the employer thinks that they did a good job or that they have some kind of connection with them. And it's important to say that many migrant farm workers who do come here do have a positive experience with their employers, especially if they're brought back multiple times. But what happens is that these individuals are brought back multiple times, and when they spend so much time in Canada, we need to provide them healthcare services. We need to provide them with medicine while they're here, and somebody has to step up to do that. So what's been great is that we spoke to 2 different healthcare providers in 2 different fields who provide this type of help to migrant farm workers. These are individuals who are really in the depths of medicine. They're going to places where medicine is not usually given in that location, and they are having to take on strategies that are specific to providing healthcare for migrant farm workers and dealing with those very specific health issues that they have in that population. So what I think is important to take away from the conversations that are coming up in the next couple episodes are really to understand that migrant farm workers represent what healthcare in general could be moving towards, in that you have a specific group that has specific health outcomes that need to be addressed. And so you need to change your way of delivery. You have to change your way of providing health services to these individuals in order to give them the best benefit. And we can't see everybody as a monolith. We have to be able to provide individualized care that is mindful of the unique challenges and the unique social determinants of health that are facing these types of individuals. I've split these two episodes into two different themes because I think each one of them touches on uniquely important aspects of providing care for migrant farm workers in British Columbia and in Canada as a whole. The first conversation that we have today is with Christelle, who is a nurse practitioner here in the Lower Mainland and has worked with migrant farm workers for a couple of months and has been interested in the equity space for quite a while.
I'd encourage a listener here to really think about it like an introduction
into providing care for migrant farm workers. We touch on a lot of issues that migrant farm workers have to deal with in their health outcomes. And there's lots of different ways that Christelle has adapted her ability to provide care and adapted her strategies in order to get to these individuals that can really show the specific health issues that exist within this population. If you haven't been exposed to this type of medicine before, or you haven't been up to date on what's happening for migrant farm workers in British Columbia, this should be a great start. In the next conversation, we'll think about more delivering care in a specific way and coming to the migrant farm workers, knowing that their ability to come to healthcare is subject to barriers that is created by immigration policy or created by the employers. So what I would really encourage the listener to do here is to listen to today's conversation and start to think about what some strategies that you think seem to work the best and what Christelle has really experienced. And in the second conversation, we use migrant farm workers as a central theme and as a central concept to then expand onto thinking about medicine as something that is coming to the patient as opposed to being there for the patient to access. And that really changes the health outcomes of these individuals when the medicine comes to them and when they are able to receive culturally competent care. So without further ado, I will pass it on to the interview, and I hope that you can learn as much as you'd like to. Anything that we chat about in the podcast and any of the information that I pass along in this introduction here is available in the show notes. So please review them if you have any interest in finding out more about migrant farm worker health outcomes and the federal program in general. Thanks so much, Christelle, for joining the show here and coming with your knowledge and your voice. I'm wondering if you could introduce yourself to the audience here and talk a little bit about your role and your background in providing care for migrant farm workers.
So my name is Christelle. I'm Christelle Kuenzig. I'm a family nurse practitioner at a community health center, which I first joined in 2021. And I was actually a new grad back then when I came across the job. And within that community health center, we have a program called, it's like a mobile clinic. So we do virtual appointments or do outreach at Langley and Abbotsford churches and set up our clinic there. And we serve migrant farm workers. So it's pretty cool. So I didn't really have a lot of experience, but I was very much interested in the population and that mobile clinic program that they had. So that's why I had joined the team.
That's awesome. Yeah, it's super interesting to hear about what happens on the more healthcare side when I've kind of gotten involved in these more on like the bike repair side.
Yeah.
So it's super cool to hear that's what's happening. Yeah, I'm wondering, I mean, you said that it was something that you came across as a new grad. Like, what do you think kind of pulled you towards this type of work?
I just had a lot of interest. Like my background is like, I'm an immigrant myself. I came here when I was 12. So I wanted to serve like a vulnerable population. And I just kind of had a lot of interest in like immigrants, refugees, and the migrant farm workers. I almost think that the job was kind of was made for me. It's interesting because kind of my final papers in school were like specifically for immigrants and like language barrier. So it was kind of interesting that it all kind of happened that way.
That's awesome. What did you know about migrant farm workers in British Columbia specifically before all this?
My knowledge was not a lot. It was very minimal. I learned a lot about migrant farm workers through my colleagues. So during like orientation and working alongside with cultural care health brokers. So we call them CCHBs or cultural care health brokers. So they provide language interpretation, but also cultural interpretation. So they actually help our patients like a lot and quite a bit.
That's great. Would you kind of consider the cultural issues in moving from a place of home over to British Columbia as one of the unique healthcare barriers that's facing migrant farm workers, or where do you kind of see that as playing in?
Of course, there's a lot of cultural barriers, like migrant farm workers when they first come in, like it's a new place, new people, not only like the language, but like the system navigation. They're very like not used to it from getting medications or their prescription to attending appointments or to doing tests. Like our clinic helps migrant farm workers kind of navigate all through that. So yeah, we provide a lot of support.
That's awesome. That really reminds me of something that I've seen when I was searching for a lot of Latino representation groups in the downtown east side, and they were talking about also having cross-cultural healthcare brokers and how a lot of patients that spoke Spanish or spoke Portuguese or any of these other languages would leave a doctor's office thinking they had a diagnosis, but they actually just had a requisition. But because that word
Yeah.
wasn't shared with them, they didn't really know what this meant. And so the next time they tried to access care somewhere else, then they didn't really know what to do.
Yeah, for sure. That happens a lot, right? Like, oftentimes, like when they see like specialists, like you said, I often would see them after because they had a lot of questions or like they didn't really get what was going on. So then I had to explain it to them again. And sometimes like the phone interpretation doesn't really capture the whole, like capture everything or like the cultural aspect of it. So it's nice that we have those CCHBs.
That's awesome. That's super great to hear. I think it's awesome that we can be pushing a lot of cultural competency and just making sure that we're giving
Yeah.
the right support to individuals where it's needed. Yeah, so I mean the audience has already kind of gotten a bit of an overview of migrant farm workers as a policy concept and a bit of a unique healthcare concept. And I know we talked a little bit about the cultural experiences of moving between a place of home and refuge over to Canada to work. But I'm wondering if you could maybe describe to the audience what the specific healthcare barriers are for migrant farm workers when they come over, maybe in the cultural aspect or maybe just in general. Like what types of issues are you seeing in the office when you are speaking to them?
Mhm. I think the number one thing is coverage. So a lot of these, I wouldn't say a lot, but there are quite a bit of migrant farm workers who don't have MSP. So we get patients that have MSP, that don't have MSP, or like have private insurance or private coverage. So that's definitely one big barrier if a patient comes in with no MSP, because then we have to navigate through like advocacy through, how could we get reduced, let's say, rates for like specialist consults or like how do we get them to do blood work. Now our program is lucky enough that we have something we call like uninsured funds. So we have like a pot of funds to, if someone needs like medication, would be able to request through that. I mean, it's not a lot, but it's something. So our clinic does try to help them out, the best way that we can. And like I said earlier, like language barriers, like I find that not everywhere like is keen on using PLS or patient language services. Now, we do try to have our CCHPs present, but I think PLS is a big thing. Like we already know that language interpretation does reduce errors, the overall patient satisfaction and also the provider. But I think people see it as very time consuming, which in the long run actually is not time consuming. And I think that's supported by a lot of research. So I think that's another main thing too, is the language barrier.
That's super interesting. I think both of those issues are something that's worth delving into. I wanted to ask a little bit about the coverage, because my understanding of the coverage for migrant farm workers is that they would be covered under the province once they arrive here and they've spent the 3 months in Canada, or at least in British Columbia. So is that the right understanding, or what type of coverage exists for these types of individuals?
I'm not actually 100% sure on how the coverage works. They usually go through like other organizations that helps them out with all that stuff, I believe. Yeah.
When we're talking about the cross-cultural healthcare brokers as being the translators and being those individuals, what kind of differences do you see in terms of outcomes between the translating service and using the cross-cultural healthcare brokers? Do you find that you can create a better connection with patients when you use the brokers, or is it just okay to just use the translation services?
Of course, like the cultural care brokers are definitely is able to build that more relationship with these farm workers. With the language services, it's really only language services, right? So with the cultural care brokers, it's like you're providing both language and cultural interpretation. And they do help like after the appointment as well. And also with language interpretation, most often it's by phone, so you don't really get that connection in person. So definitely a huge difference. And then for the insurance, I think, I think it's everyone would come in for MSP, but not everyone would have private insurance. And then if their MSP expires, so then that's when the problem comes in. It's like they have to wait for their contract and all that stuff.
Yeah, so my understanding is that it sounds like it's a lot of the healthcare coverage and a lot of the ability to use the social services in Canada is connected to being employed in Canada, and then once the employer takes away that ability, then you're kind of lost in the middle. Is that a challenge that you think you've seen in the past?
Yeah, of course. And then another challenge that I see is like because these farm workers are on contract, like sometimes you do see like that they have a like fear, right? So fear of reporting even like their health issues or reporting like a work injury, which yeah, we see quite often, and we just kind of have to respect their autonomy. But also providing them, advocacy and like education. But yeah, there's definitely a lot of fear as well because, they fear that they might lose their contract or their job. Yeah.
Totally understood. And I think that's something that's worth looking into, at least from my understanding, for advocacy, of trying to find ways to give a bit more leeway when these individuals are tied to their employer, at the same time kind of needing to have that in order to access those social services. You kind of put yourself in a bit of a questionable situation. I'd love to turn to kind of your work more specifically in those healthcare interactions, because I know you were talking about how you kind of came into this as a new grad. I'm wondering if you could describe how you think your kind of standard quote unquote practice has changed in order to meet the needs of this type of population. Like, what types of strategies have you had to employ in order to provide good service?
Yeah, I think my practice has definitely changed in terms of, even like, for example, like ordering blood work or especially for like no MSP patients. I find that kind of more modest, or sometimes I'll consult with someone just to make sure I'm ordering, only what I need to order and not more, just because of, they don't really have MSP. And also just like the whole like interpersonal interaction for someone who is not a farm worker versus a farm worker, like definitely being more empathetic of their background and why they are here, like a lot of social isolation, so we do see a lot of mental health too, on top top of like all the chronic disease. So definitely how I approach my patients in an interpersonal way could be different towards like farm workers.
Totally understood. And I think those are all experiences that have been seen in the literature as well from a lot of the information that's available in this podcast episode description that really talks about what's been seen kind of quantitatively or qualitatively, but it also sounds like you have this kind of very visceral experience in clinic that we're seeing this kind of happen on the day to day.
And another thing is like even my assessments are like, because a lot of them is virtual appointments, like I'm having to find myself like do these courses of like how to do like knee pain assessment virtually, and like because unfortunately we can't, like I can't just say, oh, come to clinic, right? I do have to adapt my assessment skills and do the best I can virtually, because most of the visits are done like by like video.
That's super interesting to hear, because my understanding, very naively, I guess, was that most of the time these individuals were receiving treatment was when they came to these health fairs or these kind of outreach experiences. But it sounds like no, it sounds like most of these are coming from virtual, hey?
Yeah, I think it's because there's like a lot of them. Like we would go, our mobile clinic would go to the like the churches and set up our clinics, but there's really only like one provider at a time for in within that 4 hours. So or 4 or 5 hours. So each patient appointment is like a half hour. So we're not really seeing a lot, but there are a lot of migrant farm workers who are wanting to be seen. So we would put them on our wait list. And that's another gap too, is that, we don't have a lot of providers. Now it's a lot better. I think sometimes some clinics, when we do in person, sometimes there's two now, and a nurse joins in as well. So that's really great that, we're increasing our capacity.
That's great. Yeah. What do you think are some barriers towards creating that type of capacity? Is there just not a lot of funding to bring these professionals in, or what do you think is kind of
I'm
creating
not,
that stopgap?
yeah, I'm not 100% sure, but I'm thinking funding.
Hmm.
And also maybe like hiring. I know we've had a hard time hiring like nurse practitioners, but yeah, definitely funding, and maybe for NPs it's been hard to find for us. I guess just because of the competitiveness of like health authorities and the contracts.
Totally understood. And it sounds like there might be a road for advocacy there for anybody who's listening to see if there
Yeah.
could be some push towards some recruitment and retention
And
for
yeah,
those types
yeah,
of
yeah.
individuals. Hey,
It's in the works, I believe.
hopefully, yeah, that sounds like a really good plan. Hopefully, there's somebody listening
But
who might be.
we're getting more volunteers, which is awesome.
That's
Yeah.
great. Yeah, what type of role do you think the volunteers have in all of this?
So we get like nurse practitioner volunteers, MD volunteers, nurse volunteers, and then I think like just a general volunteer too, kind of just helps out. But yeah, another thing that is great is like we've had a nurse volunteer with us, and then she would often do a lot of education for these patients. So a lot of our patients have chronic disease. It's like very, very common, like hypertension, diabetes, cholesterol. So, unfortunately, sometimes they're not able to go to those community clinics, for example, like diabetes clinics for, location wise, or maybe they don't have MSP. So we would often have our nurse provide that education piece.
Right. That's great. And is that type of education being done in their own language, or do you find that there's some
In their own
challenges there?
language.
That's great. That's awesome
Yeah.
to hear. That's super, super interesting. And I think that that's something that might be also worth considering, is that the compounding issues of having to have the chronic disease, but also having to migrate into Canada back and forth all the time. Like I can imagine that would be a pretty big stressor that you guys see.
Yeah.
Hey,
Yeah. A lot. Yeah. Lots of social isolation, and like just a lot of stress, not only from being away, but like the current work environment. I've heard like bullying too at work. So definitely that can happen. Although I've heard good things, but also there's also the other side where it's like not very healthy environment.
no, I think that's totally reasonable. That reflects kind of what I've read and what's in this
Mhm.
podcast description of news anecdotes of kind of overcrowding during COVID and people getting sick during there, but also like a real sense of community in Canada and having a real strong connection to the country when these individuals come over. So it's super kind of interesting and in some ways sad to see the kind of dichotomy, but at the same time, I think as long as we're doing the best we can to support these individuals, then we're getting there for sure.
Yeah. And they work really long hours. That's another like for like seeing patients. That's another thing that we also consider. Like some of them work 7 days, some of them like they can only do lab like on a Sunday. So definitely hard workers.
No doubt. And I think it's important to know that they kind of keep BC going, because without these kinds of workers that are coming over and giving a lot of support to the province, like we wouldn't really have much of an agricultural industry, and the numbers kind of support that. And so it's always frustrating to see these individuals not really feeling well taken care for when they come over, despite how much of a contribution they make to the province.
And it's kind of one of the rewarding things I find with the job is that no matter like how like how hard they're working or like how bad of a day they have, like I always like every patient, it's like, thank you so much for seeing me. Like, they're very appreciative. Yeah.
That's awesome. Is that something that you think keeps you going?
Yes, for sure. Like helping. Yeah. I think doing the job that we do at our at our community health center and the mobile clinic, I think you do have to be you do have to be, you do have to love your job and the populations you see, or else it's, and I think all of us at that clinic do have the same like passion, right, to serve the like immigrants, refugees, and the migrant farm workers.
Yeah, no, totally understood. And I think it'd be really interesting for the listeners that a lot of us are kind of at least in training to be healthcare professionals or are healthcare professionals. How do you think that your identity or that your kind of way of doing your own practice has really impacted what type of work you've been doing with these migrant farm workers?
Like how it affected my other practice, like kind of.
Sure. Yeah. I'm thinking more like if knowing your own background and the fact that you're seeing a lot of these individuals that are kind of that are in pretty dire straits healthcare wise, like what do you think keeps you going with these types of interactions if you're just kind of seeing a lot of inequity across the board like every day?
I think what keeps me going is like kind of like through the couple years that I've worked, I've seen all these barriers and gaps, and I'm just kind of like, how can we make this more equitable, right? So, and basically I just want to, and that's why I had joined the podcast, is to create this advocacy, like this population is here and they need, these are the barriers, and I hope all of us healthcare providers can collectively, help or do something to help the population.
For sure. Does it kind of sound like there's already some things in motion right now, or in motion right now? Like, what would you say is the collaboration level with different healthcare providers in this type of field?
I could only speak probably within the clinic because I'm not sure. I know in terms of cultural health brokers, there is like work going on to increase to have more cultural care health brokers in it's like in general. But yeah, I'm not 100% sure about what's been done. But like right now, basically in our team is like doctors, myself, but I'm kind of like the primary provider for these workers because in our clinic, there's really, if you collectively add all our hours, the two other doctors, there's like less than two full-time, like 1.5.
Right.
Yeah.
So a bit of a challenge there.
Yeah.
Okay. Well, I mean, I think it sounds great that you kind of have this interprofessional sort of approach to it. What kinds of benefits do you think you get from taking an interprofessional approach to caring for these individuals?
So yeah, I think it's definitely like I won't be able to take care of these patients without like if it's just myself. Like I think for not only interprofessional but also interorganizational, like we work with other organizations in terms of like, their immigration staff or like mental health staff. So sometimes we would refer out. And then in our team, so there's myself, I think we have cultural care health brokers. We have two. And their MOAs actually does, they do a lot of stuff as well, like more than just the MOA work, like calling the pharmacy, making sure it's ready, booking appointments. So they do a lot more work than your typical office. And then we have our coordinator as well, who kind of organizes a lot of the mobile clinics. I think it's important that it's not just us who's helping the population, that there's other organizations that we could kind of lean to if we have any, other concerns, because our capacity is not that much anyway.
Right. Totally understood. And I think that's very much in line with the types of experiences that I've had as well, where in some ways it's super uplifting to see, but in some ways it's also a bit frustrating, where a lot of these community organizations are the ones that have to step up to really provide a lot of care for these workers, despite how much of a benefit they give to the province. And so I don't know. I don't know if you find it frustrating, but that's something that I've kind of thought of as a benefit, net benefit. But at the same time, you have to wonder, like, where is the province in providing this type of care?
Yeah, for sure. I think about that every time I'm there. I was like, how is this fair? How is this equitable that these patients are not getting the care that they need, right? And yeah, we have patients sometimes going without insurance for like months or like years. So I'm like, how is this fair? Like, and usually the process to get to that point is like takes a very long time too. So
Yeah, no, I can imagine. What type of communication do you have with the province or with any kind of government help? Do you think that that's kind of a bit of a lost cause, or where do you think it stands?
I don't know a lot. Our director would probably know a lot more, but I know in the last maybe like couple years, a few years, like we've been trying to find a way to capture our patients, because they only could really capture MSP patients because of, like we're not able to do the billing. So now we've been like counting even like just appointment visits and then presenting that to the ministry, like, hey, we have these patients, um, you know, on by numbers, this is how much patients that we have, but we actually have this much. So just showing them like that the complexity and then the amount of patients that we see.
If you don't have their information within MSP or some way of kind of keeping it track, how do you keep track of these individuals longitudinally? Like, what's the way to keep patient records if you don't have a actual MSP number?
Yeah, so I mean, they're still on the electronic chart, but the coordinator counts like each visit on the appointment. So even if there's a direct patient encounter or indirect patient, because with their complexity, sometimes like we have to do a lot of indirect care, where whether that's medical related or maybe calling like something to do with their insurance or something like that, but capturing those appointment visits for me and then also for the cultural health brokers.
How do you think that kind of impacts later on if they go to the pharmacy or anything like that? Is there a way to keep track of what they've been prescribed or dispensed, or do you kind of feel like they get lost in the system in some ways?
I think they basically, if they've had a previous MSP, I believe you could still look them up and stuff. It's just showing not active. But
Right.
if they've never, yeah, so they would still be there.
That's
It's
good to
just
know.
whether they're active or not. Yeah.
Totally understood. And I think that's something that is probably good to know, because if these individuals just being tracked within organizations that are, have this good mindset, but we don't have a way to keep track of them if they come back or whatever, then we might be losing some valuable health information.
Yeah.
So
If there's some that has private only, then that might be harder to track. Basically, just the name and date of birth you'd be able to look up.
okay, fair enough. So there's a ways to avoid them becoming ghosts of the system or kind of being lost in the
Yeah.
system, it sounds like.
Yeah.
Hey,
Yeah.
sounds good. Well, I mean, we're kind of getting towards the end of the conversation here, but I know that there's a lot of equity issues that we've talked about so far and a lot of kind of angles. So I'm wondering if you could maybe describe to the audience what you think are some very pressing, outstanding needs that need to be addressed in order to kind of ensure health equity for migrant farm workers.
I think the main thing is like access, or one of the main things like access to care. As we know, like primary care is already like in general, there's not a lot of access. But for them as well, like, with the locations that they're being seen, there's not a whole lot of clinics that will see them or that could see them. And then like the access to like language services as well. And then I would say like mental health support, that's very important, which, we don't have a lot of either. It's great also that I forgot to mention that we also have a counselor in our clinic. And she started seeing our mobile clinic patients. So that's really great that they have access to that, because, if there's no way they'd be able to do any private counseling. But yeah, mental health support is big, especially having not having anyone here, new place, and yeah.
Totally understood. And I think that's something that we can kind of work towards across Canada and specifically within this population as well. I think this is a population that can't be lost when we're trying to push for more healthcare support and mental health care support across the board. Those are all, it sounds like really great goals and things that I think we would all want to strive for. A lot of our listeners are probably individuals that are probably pretty interested in doing some advocacy work. So I'm wondering what kind of strategies do you think that a listener who's like a trainee or maybe somebody who's in practice could really do in order to make an impact like this? Like, what would you suggest if somebody was trying to get involved in this type of field?
Volunteering would be a great way. I think it's, if you've never had any experience with migrant farm workers, but is interested to, I think you'd really love to volunteer and see like in one of our clinics, but definitely volunteering because you get that, kind of first-hand experience with the migrant farm workers. And then also just in general, like just advocating for access to care and also like use of language interpretation. I think that's a good, easy start, whether that's your migrant farm worker or maybe like your general patient, like just the use of interpretation.
Yeah, that'd be awesome. I think that's all something that those are all in things that listeners of this show would be really interested in doing, and hopefully in the future maybe get a couple of volunteers as they came because they listened to you on the podcast. That'd be kind of cool.
Yeah, that would be great. Yeah.
Sweet. Well, it sounds awesome. Well, thanks so much, Christelle, for taking the time to speak to us. It really means a lot, and hopefully there's some listeners here a bit more inspired to be able to take action in this field.
Yeah, you're welcome. Thanks for having me.
Of course, happy to do it.
Thanks for tuning in to Just Medicine.